This is a recording of a lecture given in New York City in 2026 on the unilateral cleft lip deformity. I have no disclosures, though we stand on the shoulders of giants as we refine their ideas and insights. I was once told that there is nothing further to discover in cleft care. At that time, as it is now, the textbooks tell us that the cleft side alar base is displaced laterally, and that if we want to correct the deformity, we need to advance it medially. We're told that the non-cleft side is normal, and the ideal reference for symmetry, it's the healthy or unaffected side. And we're told that the dorsum of the nose deviates towards the cleft. To quote an old colleague of ours, it turns out that they're all wrong. If we look at this simple photograph and add some reference lines, labeling positions, we can see that all of this is very wrong. Starting with the upper left image, you can see that the nasal dorsum actually deviates away from the cleft, not towards it. Again, with the upper left image, if you look at the cleft side alar base and the non-cleft alar base, the non-cleft alar base is lateral to the medial canthal line, whereas the cleft alar base is medial to that same line on that side. So in reality, it's the non-cleft alar base that's actually displaced lateral. In terms of the idea of medial rotation and lateral advancement, if you look at the image again, the medial side needs to rotate and advance towards midline, while the lateral side needs to only advance anteriorly. In terms of the non-cleft side, it's actually deformed and dynamic, and I'll show you in a little bit. So it turns out that there's actually a lot to discover in cleft care. If we take a step back and think about the embryology, how the prominence is fused together to produce the primary palate, they then give rise to all of the rich anatomic detail of the various subunits of the nasolabial region. In terms of the nose, I think this model is by far the best that we have. It was proposed by David Fisher while he was a resident, and it stands, I think, today as a really great conceptual model. It goes like this. So if you think of the nose being composed of two arch forms, the horizontal arch form following the rim of the nostril, and the oblique arch form that follows the course of the lower lateral cartilage and the accessory chain of cartilages as they insert onto the piriform aperture. Those two arch forms can be represented by paper ribbons. If you pull up the base of the ribbons apart on one side, those ribbons then start to resemble the deformity that you'd see with a unilateral cleft. If you pull the base of those ribbons apart on both sides, things start to look more like the shapes that you see with a bilateral cleft. What may not be fully represented in these models is the vector in which those displacements occur. We know that premaxilla drives the mid-face growth, and that if there is uncoupling of the premaxilla on one side, it results in an outward swing of the greater segment. If there's an uncoupling of the premaxilla on both sides, then the premaxilla swings forward. And these are what result in the drag of the bilateral cleft lip nasal deformity and the twist of the unilateral cleft lip nasal deformity. If we look a little closer at the twist, it's the uncoupling of the premaxilla that results in an upward, outward, and forward swing of the premaxilla and the greater segment. The anternasal spine gets swung the same way, as does the caudal septum and the columellar base. With that, the prolabium and the nasal dorsum get dragged along. Together, that shoves or pushes the non-cleft alar base upward and outward. Meanwhile, the cleft alar base is left behind and stays retruded. And it's these orthogonal vectors of displacement that result in the twisting collapse of the alar dome and that very distinctive twisting appearance of the arch forms of the nose. This is a 3D model that morphs between the least severe and most severe of 100 children with unilateral cleft lip. This goes back and forth between least severe and most severe, and as you watch this video, it's very, very clear that it's the non-cleft alar base and the columella that are driven away from midline, and it's the cleft alar base that becomes more and more retruded with greater severity. And so it's those orthogonal vectors of displacement that result in the cleft side alar collapse. One notion or question that's been in the literature for decades is why sometimes the nose deformity seems to be greater than the lip deformity. And the way I think of it is this. We know that it's a mesenchymal defect and a failure of mesenchyme and penetration. And so if we're looking from the outside, we're not seeing what's happening to the muscle and bone on the inside, and it's kind of like seeing the tip of the iceberg. For example, if you look at this patient with an incomplete cleft lip, there is no alveolar defect and no bony defect. Or is there? The subnasale, the midpoint of the columella, is deviated away from the midline of the face. And if you look under the surface, there's a little bony defect that accounts for the shift in the anterior nasal spine away from midline and explains why you might have a situation where there's a cleft lip nasal deformity in the absence of an overt cleft, or perhaps apparent with a nose that is consistent with such a phenotype. It also explains why some of our current classifications of clefts fail, but it gives us a measure of severity potentially. The lateral deviation of subnasale, which we call SNX, may be a surrogate measure of the defect in mesenchyme that's under the surface and that we can't see. And so if we take that measure of severity to stratify 100 images of kids with clefts that have not been repaired, we can gain some further insights into the deformity. And so for each 1 millimeter displacement of subnasale from midline, these are the changes in dimensions. In green is growth, and in red is shrinkage, and those are statistically significant values. In terms of the lip, it's as expected. The more severe the cleft, the shorter the tissues become along the sides of the cleft. There's hypoplasia here. But what hasn't been recognized is that there's some green away from the area of red. You can see that on the non-cleft side, the lip height starts to grow, the greater the severity. As for the nose, it's kind of what we would expect. With greater cleft severity, the nostril gets wider and the columella tilts further. The cleft nostril also collapses. But if you look on the non-cleft side, there's some red. The non-cleft nostril gets squished. And this is what it looks like in real life. On the left is a patient with an incomplete cleft, and on the right, a more severe complete cleft. If you look at the filtral height on the non-cleft side, you can see that it's taller in the more severe complete cleft. You can see that the nostril is more constricted with greater severity, and you can see that the tip defining point on the non-cleft side is more defined in the more severe cleft. And this makes sense because in the cosmetic rhinoplasty world, it's talked about how constriction of the lateral crural alar ring results in a boxy nasal tip. And that's what we're seeing on the non-cleft side of a child with a cleft lip nasal deformity. With the constriction of the nostril sill on the non-cleft side, it pinches that lateral crural alar ring. And so if the non-cleft side is deformed, does it change through surgery? And kind of like Newton's third law, does an action result in a reaction? If you look at these photos of the same child before and after surgery, you can see that the non-cleft filtral height shortens, the non-cleft nostril sill widens, and the heminasal tip on the non-cleft side softens. So noticing that, we wanted to know what really happens during surgery. We looked at intraoperative 3D photos so that there were no confounders from facial animation, growth, or variations in healing. And this allowed us to accurately register images so that we could detect subtle changes. On the left is pre-op and on the right is post-op. And on the right side are some numbers that indicate changes in dimensions. Once again, growth is in green and shrinkage is in red. If you look at the nose, things are as we expect. The overall nasal width narrows and the height of the ala on the cleft side becomes taller. The nasal sill narrows, but maybe what hasn't been fully recognized previously is that on the non-cleft side, the nasal width increases. In terms of the columella, it stands up on the cleft side while it sits back down on the non-cleft side. As for the lip, everything gets stretched out and everything becomes greater in its dimension, but with that stretch, we're dragging the commissures together and creating a little bit of a microstomia. As for the filtral heights, as it grows on the cleft side, it shrinks on the non-cleft side. So perhaps the columella is in the nose, and the deficiency in columellar height is perhaps more apparent than it is real. The true columellar height may be anticipated preoperatively by correcting the nasal base displacements and supporting the rim. So it begs the question, does the columella really need to be lengthened? Do we actually need to be putting incisions on the columella with our primary repair? And in terms of presurgical molding, do we actually want symmetry prior to surgery? Or should we anticipate that things are going to change with surgery, and with that, accept that there's asymmetry? For example, in the image in the upper portion on the right, I think there's a real risk of producing a meganostril. Based on our analysis of outcomes at 5 years after surgery, it was really the shape of the dome that was most important. And so, if on the image on the right there's asymmetry and apparent shortness of the columella, that actually may be okay, and that actually may be just right. We don't want to overdo our molding. As for the non-cleft filtral height, it shortens through surgery, and it's likely due to tension of the muscle repair. And so this is somewhat reassuring when the lip height discrepancy is large, but it also issues us a warning that we need to be careful of over-elongation if we are using the non-cleft side as a template. And so these days I go back to this table generated from that study where there are some pre-surgical measures that can predict how much the non-cleft side filtral height shortens through surgery. As for the anatomic subunits, they change through surgery, and normal is only revealed after surgery. If you look at the shape of the subunit of the upper lip as it transitions to the nasal sill, this is in white. It's an inverted V pre-op, but post-op you can see how a valley has developed in the middle of this, And so that anatomic subunit changes through surgery. With the fissure repair, the adjustment for that change in shape is inherent in the system of marking, whereas for a traditional Millard, it doesn't follow that anatomic subunit contour. And so if folks are doing Millard repairs, it may be worthwhile considering a modification such as that proposed by Onizuka. Ultimately, all of this provides us with some universal goals to untwist the deformity. We've got to centralize the columella. We need to advance the cleft alar base anteriorly, and then we need to balance the alar base positions. Meanwhile, we need to anticipate that there are opposing changes. And so what do? I use a fissure repair. I really like this repair. In particular, it helps to identify points of closure along the nasal sill that are going to produce the nose that we want. I use what's been called a foundation-based primary rhinoplasty. It's effectively the idea of focusing on the septum, the sidewall, the floor, and the muscle to correct the nasal deformity. I do a primary caudal septal repositioning, a release of the upper buccal sulcus if needed, dissection along the piriform aperture if it's needed, and then if we need to, a transition in the plane from supraperiosteal to subperiosteal to enter the lateral nasal wall. And it's through that access that a release can be made along the cleft margin. A releasing incision then allows the alar base to be brought anteriorly, and we can close mucoperiosteum to robustly close the nasal floor. And this is what stabilizes the alar base in its new anterior position. With muscle dissection, it creates a dead space underneath the columella on the medial side. And on the lateral side, a relatively aggressive dissection to produce an empty triangle that's devoid of muscle lateral to the nasal ala. And so with inset, I like to see that the columella becomes centralized and the cleft alar base is supported in its more anterior position. I do sutures in the scroll area, as well as alar transfixion sutures. And in these photo strips, you can see how correction of the septum, floor, and sidewall only, with no nasal tip dissection, produces profound changes in the shape of the nose that are finalized with skin and muscle inset. On frontal view, again, with correction of the septum, floor, and sidewall only with no nasal tip dissection, there are profound changes in the shape of the nose, with the final adjustment made with skin and muscle inset. I previously published the outcome of the middle 20 of a consecutive series of the first 100 patients treated in practice. They're arranged in order of severity on the left, from least severe to most severe on the right. In this series, there haven't been any revisions, and what I anticipate is that these kids will likely still need septorhinoplasty in the future because the deviation of the bony septum. But with that procedure, it will be a primary procedure with no scarring, intact cartilages, and malleable soft tissues. With this foundation-based approach to rhinoplasty, can we dissect the nasal tip? Well, absolutely, but I would just issue a warning that if the tip is corrected with inadequately balanced foundation, you get appearances like this, where the tip cartilages are together, but there's still a very obvious nasal deformity because the nasal base has not been corrected. And so what I've shown you is how to leverage these universal goals to produce favorable changes on the surface. However, what's happening underneath, we've actually just masked. David Fisher has quantified some of the changes in bone, and Alex Kane has demonstrated how the asymmetries extend to the cranial base. Roberto Flores has pointed out that later in life, the septal deformity extends far posterior. And so in collaboration with Dr. Lunju Lo, we further quantified the skeleton prior to repair. And we found that the deviations of the nasal vault were similar to those at the surface. But in terms of the septum, there was only a single bend in it that occurred anteriorly, driven by displacement of the intranasal spine. And so there's a great complexity that's unknown of how that develops into the very complex shape that we see at maturity. As for the shape of the skeleton, we noticed how the shift of the nasal pyramid and the cleft side protrusion produces a sigmoid collapse of the cleft side piriform aperture that may obstruct the nasal airway with correction of the septum to midline. And that sigmoid collapse persists to maturity. And so, for now, when I do definitive septal rhinoplasty at maturity, I spend a lot of time focusing on a large outfracture on the cleft side to open the nasal airway. And so there's still a lot to discover in cleft care. In the meantime, this was my first paradigm shift. This is my previous teaching slide. I used it for many years where I told trainees that we need to move the cleft alar base forward, inwards, and upwards, but it's totally wrong. And this is my new teaching slide where the focus is on the columella and the non-cleft alar base moving medially, while the cleft alar base needs to move anteriorly. And so rather than calling Millard repair rotation advancement, perhaps it's more accurate to call it rotation and advancement and AP advancement. Paradigm 2, neither side of the cleft is normal. It's subtle, but if you're looking for it, you can see it. And if you carefully document what's happened during surgery, you can see that that side also changes. As for the nasal dorsum deviating away from the cleft rather than towards it, that's the part that's kind of crazy. Because imagine this. This is an example of a patient who we've straightened their nose. We've shifted things to midline. But if we followed what the textbooks told us and moved the nose the other way, this would be an absolute disaster. So how did we get things so wrong? It may be a little bit of an optical illusion. For example, if you look at this image, the two boxes, A and B, are the same shade of gray, even though they don't look that way. It's the context that's throwing us off. And if we add references, we can see that A and B indeed are the same shade of gray. And so when it comes to the cleft lip nasal deformity, we have context where review articles, textbooks, board exams, and all of these diagrams show us one thing. We might believe that the cleft alar base needs to move medially. But if we take a step back and place a reference, we can see that reality is quite different. So let's change. Moving forward, let's avoid talking about the healthy, normal, or unaffected side. There's a non-cleft side and there's a cleft side, and that terminology may be more appropriate. Let's be careful with the term rotation advancement because in reality maybe it should be medial rotation and advancement with lateral anterior advancement. And let's not talk or think about matching or templating the cleft side to the non-cleft side, and instead recognize that Newton's third law does apply in this situation somewhat, and that we ought to be focusing on how to produce harmony through balance. Let's recognize that there are some illusions that differ from reality, and that illustrations can introduce some inaccuracies that don't reflect reality. Last, let's recognize that we can make mistakes. This is a quote from me from several years ago. Ezgi, you've mislabeled the landmarks. I'm a cleft surgeon and I know what I'm talking about. Ezgi Merkan is a computer science engineer with no medical training. We argued about this for a while until I realized that it was me who was actually quite wrong. And so there are universal goals to correcting the unilateral cleft lip nasal deformity. We need to balance the prolabium, we need to level Cupid's bow, we need to centralize the columella, advance the cleft alar base anteriorly, and then balance the alar base positions. In the meantime, we need to anticipate opposing changes from one side to the other. And so let's evolve based upon what we've learned. I've told you a great number of things, but some of what I've told you may be wrong, and it's up to us to work together to improve things so that we improve the care for our patients as we move forward to the future. I'd like to dedicate this in memory of one of the giants in our field who recently passed away. Thank you.